use this one. Okay. So, yeah, I will try to speak on perspective of oculoplastic, but as well as member or chairing the committee of the medical legal for 10 years in Dubai. So you will see also the other side. So the purpose of the talk for me is, of course, but it was said several times, to identify the risk, to avoid complications, and how to manage them when it happens, to whom it can happen, and how this can happen. Risk of complications was extensively discussed, linked to the patient. There are conditions that are linked to the patient, but missed from the doctor. So then we end up with the complication, anatomy, evaluation. Risk of complication linked to surgeons. We see that in the medical legal. We know that probably the surgeon has no experience or has no clue, and he's not necessarily an oculoplastic surgeon. He will go for blepharoplasty, but he comes from complete different background. And how to manage when it's possible, and that will be discussion. It's very common surgery, the most common one, I think, in oculoplasty, at least in our region, for cosmetic purpose. So to avoid the complications, of course, it was said several times, careful preoperative assessment, comorbidities have to be known. Patient with diabetes with HbA1c of 12 have to be avoided from surgery and removed and wait for the diabetes to be fixed. We see this situation sometimes, and we tell to the ophthalmologist, why did you not check this? Oh, doctor, I was just dealing with the oculoplastic problem, but he is 12 HbA1c. As a medical legal, you look at the whole page. So this is also something that we have to be concerned with, because he ended up with complication because of that. Psychology aspect of the patient. This is the most important. I think I have one slide that summarizes our discussion today. And patient expectation. Patient comes with an idea, say, doctor, I want to have something in my eye, and you are here. So we are here every day. We try to solve this equation, which is sometimes very difficult. Patient is very happy when she leaves your clinic. She understands that what you are going to do is this. You will offer this to the patient. She's expecting this. You are very happy because you understand that this is what she's looking for. So you will do this, but she's expecting this. That's the key moment. This is where the problems will start. So in the clinic before the surgery, this is the critical moment to understand and to decide. And then it's like expertise, which surgery you explain to the patient, but this is not really important. It's important for us as professionals, but for the patient, it doesn't matter. She would just want to see the result, or he doesn't want, he just want to see the result. What you did, how did you explain, lateral flap, external, internal, doesn't matter for him. He wants the end. And of course, to adjust, I say to my junior doctors, if you know one technique and you keep on performing it always, it's like someone who knows to drive only straight. The moment you have a turn, you will just go outside the road. So if you know one technique and you apply it to all the patient, for sure, one day will have a complication. You have to adjust and adapt to every patient. Every anatomy is different. So as we discussed on those on transconjunctival approach, it's shiny. People like it. Oh, it's scarless surgery, laser based techniques. All this patient likes it, and of course, the other adjunctive treatment that you can add to the patient. Sometimes everything is fine, but the patient is unhappy. She wants something else, and then you can offer. To whom? To give the surgery. This is my son when he was 6 months. Now he's 24. And this is an old lady that I met in Morocco for cataract surgery. So at which moment? We have here in the UAE ladies of 18, 20 years. I'm sure that my colleagues have the same experience. Doctor, I want fox eye, cat eye, and they are 18, 20. So we need to decide with whether to operate or no, and it's a really daily request. Of course, realistic objective. If they come with the picture, you say it will be difficult to have this. So now some complications that I see in the medical legal, also in my practice as a second opinion for surgery, and I believe that it's because of the surgeon lack of experience. It's discussable. We can discuss about it. So beginner complication, I call it. And you can see this patient, she came with an incision right in the middle of the eyelid, and she's not happy with this scar. And we can see even this, it's not working, this pointer. And we can see here the last part of the stitch, which is like a cross. And the patient ends up with lid retraction and a bad scar. So it's difficult to correct, but this is, I believe, because of a lack of experience. Let's go next. Incision position. Dr. Osama, he discussed this in his topic. We can see that the patient here is very bad. This patient given to me by patient say, doc. Yeah. So here, this picture was given me by the patient. Say, doctor, I had this incision by the doctor who I complained for, and okay, thank you. And the other one you see, it's like very basic mistake. all of us, we will never extend to this place, especially if your patient is diabetic or if he has a problem or you remove to the suture. So you know that here it will be a problem and it can end up like here. This you can see this patient, she had retraction, and you can see also the shape of the incision. All this, I believe that they are because of lack of experience or lack of training. So let's go further in the complication that we see. In this patient, you had, of course, the same incision that the previous one, and large rejection of the skin. She ends up with a round eye and lid retraction, which will be quite difficult to correct. Push the limit. Here, this patient had, the doctor did an incision. I'm not talking about oculoplastic surgeon. Now, there are a lot of other surgeons doing surgery. So this lady had an incision. We can see clearly that something has been done here, but he did not remove the fat. He just did the incision, tightened the skin, and left. Of course, she's not happy and she complained. So this, I don't think that he had any training, because he considered that, yeah, surgery of the upper lid is direct resection. We have an excess of skin, just go and direct resection. So the patient is not happy, of course. This is a patient that I've seen in France, not in the UAE, but it's all lack of experience. So what is the solution? Training, cadaver dissection, go to meeting, take a mentor, and learn the surgery. Risk of a complication linked to patient condition. And this also involve the doctor, because he missed this condition. This lady, she's 20, but she has severe floppy eyelid syndrome. She wants surgery, but we need to be very careful. Similarly, patient with floppy eyelid, it's usually often missed. I don't know, it's just to pull the eyelid. I do always pulling the eyelid, and I always advise my patient to meet an apnea, sleep apnea doctor, to be sure that he doesn't have sleep apnea, because we know that it is sometimes connected. Of course, many techniques to repair. This is the most common complication or problems that I see here in my practice. I see patient ladies like this one will go to a doctor and shop many doctors for blepharoplasty. And the other doctors, they don't know about Graves' orbitopathy. They don't know about the thyroid disease, and it's our specialty. This is where we are superior to them. So these ladies, they all came to me here for blepharoplasty, and I know that these patients are not for blepharoplasty, and it's sometimes it can be very minimal here. We have to be very professional and go for the workup of the thyroid disease, and they are all three thyroid disease. And if we go for blepharoplasty here, we can end up with some problems. The common complication as shown before, eyelid position here, very easy to correct, but you lose the patient, you lose her friends, and you lose the neighbors, but you can correct it easily. So this one also, it can happen to us as, like say, doing surgery daily, but this kind of simple complication can happen, but we have to repair it. But the patient is very unhappy, as Dr. Osama mentioned. Small things, but making her life a disaster. So these are the technique for the more junior to do. We can do without contotomy, with contotomy. There are many techniques, contopixy or contoplasty, depend on how you do. And I usually rarely do contotomy in patient with blepharoplasty. It has to be very soft change of the lateral countries here or repair. Eyelid retraction, very common, but I believe that it's more difficult to repair. You have to explain to the patient, now she shifted to a medical problem with the lack of thalamus corneal exposure. We are going for medical repair, but she still with the mind and the mindset of, I am a cosmetic patient. And it's very difficult to tell her that I will take some mucosa from your mouth and to repair, etc. Early stage of management of this patient, you can see here, she has lid retraction, simple conservative massaging treatment. You massage the eye, and we sometimes inject steroids, 5-FU, depending on what's available there. And you can see that the patient, after 2 months, she started to recover almost back to the normal, and we can sometimes add some more surgery. So the usual techniques that I use in my practice is to get mucosal flap. One slide more and then it's finished. So mucosal flap, can you, yeah. So there are different options. You can take any posterior lamellar repair, grafting, pericardium, etc. And the whole idea is to extend, to lengthen the eyelid. Threatening vision, we need to know that the patient is on platelet, aspirin. It's very important to do the medical job, not only the surgical job. We can end up with this patient with orbital cellulitis. One of my patients recently in the medical legal committee, she ended up with all face cellulitis post blepharoplasty. Of course, very unusual, but threatening the vision, 1 over 10,000 surgery, retroorbital hematoma. You have to know it and to take the correct management when it's needed. Thank you for your attention.
Thank you very much. I think that's probably one of the best talks I've listened to, and I think we've had a wonderful course today. We do have another 10, 15 minutes or so. This is a good time to really pose all the questions to the experts at the front. The row, not me, pose it to all of them. I don't know the answers. But I think for the beginners, I think it's very important to realize that when you're looking for a patient to operate upon, try to identify the patient you do not want to touch. And that only comes from experience. And one of the takeaway messages from aesthetic procedures, I don't know about refractive surgeons in the crowd or not, never ever operate on a patient after one consultation. It's very tempting. They come and say, I want this, I know exactly what. They'll say yes to everything. You think you know anything about this, everything about this patient? You'd be amazed the number of times what they remember from what your first conversation was. Yes, there are very motivated patients where realistically you can say, I can do that. It's very easy. It's a 1-to-1 ratio. There's a 50, 60-year-old experienced lady who knows what she's talking about, as opposed to a young lady who actually sometimes they do not know what they want. Be very careful.
Stressed in our lives that even patients facing major psychological pressure, they find their getaway in being operated, so they sympathize. We will not talk about the divorce now. We're talking about you have done a surgery and you just need to be comforted, and we just forget about the main problem. So many of those would come to you to find a getaway, and then they look at themselves, what have I done to myself? What have you done to me? And then the blame will go on you. So this is a very good tip that, suicidal or they'll kill you. It's either ways that, not the first consultation, the second consultation. And you can see, the grieving patient, the stressed patient, the wanted to get away patient. We would have to recognize those as well.
Actually, yeah. So can you give us, since you sit on the board, medical legal cases, not infrequently when you're a good surgeon, you'll have a patient who's had surgery number 1, surgery number 2, surgery number 3 by your friends, colleagues, plastic surgeons, oculoplastic surgeons. How do you know when to touch them and when not to touch them? When do you refer them back to the original surgeon? When do you fix something that only you think you can fix and nobody else can fix? How have you handled those situations? This is very important as you start doing more.
Usually it's based on the first consultation with the patient, because most of the doctor who will be sued, not necessarily the first one who did surgery. I have an example of ENT doctor. He did blepharoplasty for the patient. It wasn't perfect. Then she went to another doctor to do the surgery, but he did the surgery within a month. He did not want even for the healing. She complained not on the first doctor, but the second one. As a medical legal here, with the rule of the country here, we cannot call the first surgeon. You cannot say, okay, that was the first problem. Despite me, I know that sometimes the first indication was wrong, but we have to follow only with this doctor. This is unfortunate that if I was in the position of the doctor who went back, first mistake, he went too early for the surgery, conservative treatment. And the second mistake, I believe he could have sent it back if he was expert enough to understand that the patient wasn't a good indication from the beginning, because we know all that the mistake was from the first one.
Actually, we are dealing with not patients subjectively. We are dealing with psychological, social problem, and so forth. One of them, I want to take the opinion of every one of us, because we are doing it. I tell the patient that you have, immediately after surgery, you have swollen eyelids and so forth. Are they okay for you? Said okay. Say yes, but tomorrow and the day after tomorrow they will be worse. Don't ever call me. I mean, I give Serodase drops, Serodase tablets, whatever, oral. I give ice packs and so forth. But actually, anybody has got really a kind of innovative idea, or out of the box idea, how to reduce the first 2 days, of swollen and hematoma. And this is kind of unavoidable. And this is usually patients they don't actually realize, and they are worried, and they phone you.
I have one comment if you want. Allow me to add it. We said that experience is for the complaint, our experience, the patient, psychology, etc. But your worst enemy in the complaint is your colleague. So if you don't understand yourself that you are expert, I'm having second opinion. I'm working with colleagues here. I'm having second opinion. If I was stupid enough to understand that, oh, I'm just having second opinion from my colleagues, and my patient also are going for second opinion to Dr. Walid and so on. So if you miss this part, you will be the problem, and one day it will be you. So most of the complaint we are having, because we are interviewing the patient, we take long time with the patient, we take a long time with the doctors, and we are recorded. It's not like we decide. So we have the medical legal committee, but we have the DHA here that records us, know what job we do. So when we interview the patient, sometimes it takes an hour, and the problem came from another colleague who he met, and he said that, oh, it's not super good job, so I can do better. Because this doctor doesn't know that his patient also are chopping other doctors and seeing other. So I think that we as doctors, we have to be more conservative. Yeah. In French, we say confraternel, means like confraternel, like Hawiya, yeah, like it's. Consent is very important. The consent is, we look at the consent because the consent is it detailed consent on? I just shifted to a new hospital recently. So when I look at the consent, it's very general. I see it as a surgeon, but as I see it also as complaint, eventual complaint. It's too short. You have to make all the detailed, and you can print out. For example, French Society of Ophthalmology, I said to Dr. Gang, I work in the UAE, but I'm also French doctor, I work there. The French Society of Ophthalmology or oculoplasty, we have a list. It's all paper, and we give it to the patient. Most of the complications are there. This complication of 1 over 10,000, retroorbital hematoma with loss of vision, it is there. And we've seen patient here. So it has to be perfectly detailed. Otherwise, the patient, because yes, it helps, because the patient will tell you, doctor, yeah, Dr. Usama, the patient will tell you, this complication that I had, you did not mention it to me. And then you take your paper, say, no, it is here. We as a medical legal committee here, we can say, okay, the doctor mentioned to you that. It is an agreement between you and your doctor. This can happen. I tell to the patient yesterday, yeah, detailed consent. I told you, I give you an example. Detailed consent for us in France, it's a must. We have a list. The society, the oculoplastic society or the ophthalmology society mentioned everything there. A patient said yesterday, doctor, is it risky? Just Botox into the lacrimal gland? Yeah. I told her, listen, in our French insurance, yearly they will publish the number of complications. Dental is 1.5 million procedures in France all the year. We have 1 or 2 cases that die into the office of the doctor. Yeah, it's a complication. So we mention all these things. I tell them, you accept the risk for cataract surgery. 1 out of 1,000 or 1,500 surgeries will end up with endophthalmitis. So they know that, and it is mentioned. If the endophthalmitis happened to him and the doctor explained to him that there is no mistake in the surgery, we cannot blame the doctor. This can happen. Yes. Yeah, Professor Ganga said, okay, your neighbor there, someone is inside the room. But this person who is inside the room and telling him, okay, we understand, etc. The day of the complaint, he will be against you. He said, no, doctor, no, he didn't say that. In your medical legal, Dr. Sama, the medical, in your...
In fact, there are in fact 3 levels to a consent. There's a consent that you get them signed, and that is legally useless. It just gives you a sense of comfort that they've signed a document. Then there's something called an informed consent. That's exactly what he's talking about, mentioning risks and complications, highlighting even blindness and death. In fact, like you said, you can have complications from orbital injections, periocular injections, strokes, blindness. I think all our procedures should include blindness and death. Then the third phrase is a valid informed consent. Different countries have different laws about how long is a consent valid. By medical records or legal records, a consent is for life. But every country and every state determines how long. For example, in Singapore, they arbitrarily decided it's 90 days. There's 91 days that consent is invalid. So you'll have to figure it out. So anyway, we'll talk more about consent in a moment. We have other questions.
Just
No, let's take more
the-
questions from the crowd. Yeah.
the question to all the speakers. Thank you very much for all the speakers. But yeah, I think it's working. No. Are you used to it's a scientific away from the medical legal? Are you always it's a routine for you to do a medial lateral canton tuck or lateral tarsus strip in your transcutaneous bleph, lower lid bleph? Is it a routine? What's the question? Are you doing regularly a lateral tarsus strip or a lateral tendon tuck or some sort of shortening or stretching to the lower lid? Blepharoplasty is one of the questions. Second is what I feel with the issues with all our cases, which is making troubles. All of us doing this. Just I think in my opinion, some security. Give them some feel of security, and that you are going to fix it. Don't leave them without hope. This is what works with me. I'm giving them my phone number, although I'm sometimes receiving calls 1 p.m., 1 a.m. actually. But I mean, maybe the security they don't feel secure, and just tell them that okay, we are going to fix it. It's going to reach somewhere that you are going to be, happy about it. I'm not going to leave you without. Instead of making it like a fight, maybe this will work with many. They are still having the same stress we all have. This is my experience. I'm just going. I'm sharing the phone number and doing the things which is working with me. And at the end, we are all making complications, and it's all like that. And I want to hear from you because my first mentor, Dr. David C, is doing the lateral testicles fixed. It's always he's doing this. I want to know because I stopped doing that. So I was just.
Okay, thank you, sir. In my experience, if the patient is younger, in young patient, and then when I examine before the surgery, there is no any laxity of the lower eyelid. Usually, I only did with the transconjunctiva to remove the fat, but I didn't do the cantopexy on cantoplasty. But in elderly patient, usually we need to at least is cantopexy, not to do the cantotomy on cantolysis if there is no laxity. But I did the reattachment or tucking the lateral part to the periosteum to make it more stable. That's why if they have a skin so excised, it's very useful for them. Thank you.
Yeah. My question, excellent presentation by everybody. I am basically ophthalmologist with a special interest to this plastic things. My conclusion is if you have enough good cases, clean cases, don't touch complicated cases. That is the advice from my side. But I have a patient. Last month, a patient was brought from Germany, child, 3 months old. All 4 lids have double row of lashes. Inner row is grayer than the outer row. No watering, no redness, no irritation. Child is very comfortable. In Germany, they advise surgery. From somewhere they know me or so. They came Dubai, so I saw. I gave my opinion, nothing to do. Because child is symptomless.
There's a famous word for that, masterly inactivity. You become a master by doing nothing. And sometimes that's exactly what some of our senior surgeons are talking about. Go ahead, sir. Yeah. So I think you're right. I think the point is very well taken that sometimes doing nothing is perfectly is all right.
If you have
And sometimes you may have to go the extra mile.
This
If
is
a
the
patient
wisdom
is
of age,
unrealistic, make them beg you for the surgery. Especially when you think, oh my God, there are red flags here. Try not to touch them. This is when you know who your friends and enemies are. Say, I've got a better surgeon down the street. Please go and see them. Because until you've touched the patient, The patient who's coming for a second, third, fourth opinion is somebody else's patient. And like you rightly pointed out, the moment you've touched the patient, you're left holding the hot pan.
That's
And
right.
that's very bad. Dr. Biparsha is quite an experienced
So
plastic surgeon.
anything anybody has to add whether to touch this child or not?
It is a symptomatic child. You're talking about a case of
Yeah, I'm
distichiasis.
talking easy asymptomatic. To my mind, he should not be touched.
No, but keeping in mind that sometimes when we label a child or an adult as asymptomatic, they'll never come to the clinic without the mother or somebody saying the child has got wet, sticky eyes or tearing and all the time. Then you're obligated. A child will never complain. Likewise, I have patients who have
He's
Graves'
too young.
disease.
He's only 3 months.
I know, so you may have wet, sticky eyes. If there's no wet, sticky eyes, there's no keratopathy, because usually at that age they have very fine lashes. You're right. Conservative management is perfectly all right. Dr. Biparsha, what's the worst complication you've seen following aesthetic blepharoplasties?
I didn't get my answer.
Sorry, sir. Yeah.
I didn't what to do. How long to wait till the symptoms appear, or the child starts complaining when he becomes big.
When Biparsha, when to answer the question.
Okay. At the moment, it's negative.
But these children usually they improve by their own. They spontaneously improve.
No, distichiasis. Distichiasis.
The problem is the parents. Because they have gone to a person, to a ophthalmologist in Germany, and they did not believe, or they had a doubt, they wanted a second opinion, so they landed up with me.
You're perfectly all right to give your second opinion and leave it.
Electrolysis in these patients, just electrolysis.
No, they respected my opinion and they said, yes, we will not do anything. But I'm asking my
But that's not the end of the story, because the child is still growing. The lashes are going to become thicker. The lashes are going to become longer. The child is going to have wet, sticky eyes. They're going to be rubbing the eyes all the time. So, right.
How long? 1 year, 2 years, 10
Forever.
years?
Forever.
Okay. And if at all we have to do procedure, what procedure we want to? Suppose symptoms
this
appear.
is an aesthetic symposium, so we'll talk about distichiasis later. I'll give you the email of each of the experts and you can contact them in detail. But bottom line is a symptomatic child, I think we are obligated to treat. Children themselves, even they have retinoblastoma, they're asymptomatic. They're not complaining they can't see. They're not saying they have a squint, but we manage them.
Patient retinoblastoma don't come to you.
No, I'm just telling you. So asymptomatic in itself doesn't mean anything in a child. Refractive errors, amblyopia, strabismus are asymptomatic disorders. Child never complains, but we are obligated to treat if it is affecting the quality of life or the life itself or the vision of the child. So determining that whether the child is really going to suffer from consequences, even fluorescein staining, I've realized, because we do a lot of epiblepharon, just even putting a fluorescent strip in a child is difficult. We use hypertonic or 2% fluorescein, wait for 5 minutes, and if you look at the slit lamp, you see the amount of keratopathy. With a pen light, you'll never see the amount of keratopathy a child has. Symptoms such as photophobia, child going out shuns the light. Those are the subtle cues the child is symptomatic rather than child coming to the clinic and saying, I'm having difficulty. So anyway, aesthetics, any last two questions? I think we have to get out of the right?
My question is, even suppose he becomes symptomatic, what you will do? I want to know the surgery, what you want.
The technique of distichiasis, you're right. You can do multiple electropilations if you want, but that means multiple GAs all the time. Some people do lid split and cryotherapy. The less invasive you'd start off with, the better. If you're able to reduce the 25 lashes to 15 lashes, you've done a lot of favor.
No, it's a complete row too.
No, even it's a continuous row. Yeah. With electroepilation also, you can probably cut down by 50, 60, 70%. Then you're left with only a handful of lashes. But if you're enthusiastic about it, you can even cause posterior lamellar scarring and a cicatricial entropion. So try not to do too many invasive techniques. Try to do minimally invasive techniques. And then if it's a localized sector of lashes, then you can go ahead to a surgical approach. I mean, that's my personal
it's a symmetrical, all 4 laid.
Yeah. So anyway, Anas,
thank you.
Question. Take the microphone, please. Dr. Anas is a young, budding oculoplastic surgeon from the West Bank of Palestine. Go ahead. He's pediatric neuroophthalmology and oculoplastic trained.
Yeah, I'm a past fellow of Dr. Gang a few months back. So I have a question to Dr. Yunia and to the faculty about titration, the fat remover on lower lid blepharoplasty. We know that the orbital rim is our border, but I mean sometimes you ended up with overcorrection by just like or undercorrection by going only to the rim. So like any tricks that helps us in removing the lower lid fat, I mean, so that not ended with an undercorrection, because sometimes you have like to press over the globe, get some of the fat up and take it out. I'm not sure if you have like, and from your experience, any other tricks or ideas that help us in that point. Thank you.
We have 2 minutes to get out of the room. Go ahead. We'll have a good faculty photograph after that. Yeah.
Yeah, thank you. This is our tricky. Maybe before the surgery, of course, we should be examine the patient well, because there is drip pad. Not all the patients have a perfuse all the pad. Sometimes they only have in the medial part or lateral, or they have all. And we know about the skin also, yeah. The elasticity of the skin, because when we did remove the fat and slightly under corrected, I mean not all the remove with the fat, but we concerned to do this repairing or excess skin and then tightening the skin. It can make it good position the fat. Yeah, it's a lot. It's usual. That's why not to remove all the previous fat. I think, because even though that is can make it the hollow more previous. I think some of patient doesn't want to take the hollow. That's why sometimes we should be reposition the other part of the hollow at the usually in the medial part. Yeah, that's why when we push the for the superior eyelid, we look it and then I think don't do it beneath the orbital limb. We should avoid it to took all the fat beneath the orbital rim, just plain of our orbital rim or slightly at the orbital rim part, and then tightening the skin is very important. Yes, yeah, yeah. That's what is elderly patient. I think at least we do the cantopexy first. Okay.
I think with that, I think we should probably call the session to an end because I think there's another session starting in 2 minutes. Oh, photograph. Okay, yeah, of course. Yeah, actually, photographer is here. Can you cover all of us? I think the whole crowd, not just faculty. Dr. Salam, he's going to take all of us, the whole crowd. Yeah, thank you very much, everybody. And of course, you can get in touch with the faculty. Yeah, the whole crowd.